A 63-year-old male presents for a brainstem tumor resection in the sitting position. What are the advantages of the sitting position for craniotomy?
There is improved exposure to the posterior fossa, better drainage of the cerebral veins and CSF, and less pooling of blood in the surgical field.
What are the disadvantages of the sitting position?
There are many disadvantages, including increased risk of venous air embolism, decreased cerebral perfusion pressure, increased pneumocephalus, venous pooling, and injuries to the common peroneal nerve.
Would you use any special monitors for the sitting position?
I would use a precordial Doppler to better detect air emboli, place an arterial line to better monitor cerebral perfusion pressure, and place a central venous line to allow aspiration of potential air emboli. If an external ventricular drain is already in place, I could also use that to better monitor and improve cerebral perfusion pressure.
What is the significance of a fixed split S2?
This sound could indicate the presence of an atrial septal defect. If present, a TEE would be needed to rule out an ASD. If one is present, the sitting position becomes relatively contraindicated due to the increased risk of air emboli entering the arterial circulation.
How can you prevent venous air emboli?
Minimizing head elevation, maintain adequate hydration to increase CVP, avoid nitric oxide, and ask the surgeon to use bone wax.
How do you detect a venous air embolism?
A precordial Doppler or TE are the most accurate methods for detecting a venous air embolism. In addition, significant air emboli will cause hemodynamic changes.
Where is the precordial Doppler placed?
It is placed to the right of the sternum between the second and fourth ribs.
What signs may make you suspect venous air embolism?
A decrease in end-tidal CO2, tachycardia, hypotension, cardiac arrhythmias, and hypoxia would make me suspect an air embolism. I could then look for more specific signs like a mill wheel murmur or roaring sounds from the precordial Doppler.
Where do you place your central line to best aspirate air?
I would aim to place the tip of the central line 2 centimeters below the cavo-atrial junction.
How do you place an EKG-guided catheter?
The EKG tracing informs you of where the tip of your catheter is located. In the mid-atrium, the tracing will be biphasic. The catheter can be withdrawn slightly from that point until the P wave is maximally positive, indicating it is just past the cavo-atrial junction.
The patient becomes hypoxic in the middle of the case. What do you do?
First, I would check his hemodynamics. Then I would check ventilator for any changes in airway pressure or end-tidal CO2. I would hand ventilate the patient and listen for equal breath sounds, knowing that pneumothorax is a possibility with central line placement. Depending on the information I gained from the initial assessment, I would narrow the differential and investigate further.
How do you treat an air embolism if it occurs?
Ask the surgeon to flood the field with saline to prevent more entrainment of air, lower the operative site below the level of the right atrium, temporarily occlude the jugular veins bilaterally, and switch to 100% FiO2. I would then aspirate via the CVL and provide the hemodynamic support as necessary.
Would you give PEEP?
PEEP is controversial in this scenario as it may increase the risk for paradoxical air embolism or worsen cardiovascular compromise. It may, however, help limit further air